مؤنس Academy. From bedside to best practice by Professor Dr. Ahmed Mounis, Professor of Gastroenterology Hepatology at Shams University. Here we have a 25 years old man come to you with chest pain. This pain comes and goes randomly. He also complaining of sour, itching mouth every time he eat raw apples. The pain persists despite of 2 months trial of high dose of PPI in form of omeprazole 40 mg twice daily. You decide to perform an upper endoscopy, and here is a picture of upper endoscopy. Then you from the esophagus, then you decide to take a biopsy, and the biopsy come back saying that 35% of high power field is eosinophil in the distal esophagus and only 5 is eosinophil in the upper esophagus. What's the next step for treatment of this patient? You will add histamine receptor agonist as the distal esophagus, suggesting that the inflammation is related to breakthrough the acid reflux, or you recommend a niacin fundoplication to control acid reflux, or you tell the patient to stop eating raw apples because this causes infiltration of eosinophil in the esophagus, or you offer him or give him topical steroid and counseling for elimination diet. To answer this question, you have to know the diagnosis, which is oral allergy syndrome. It's also called pollen food allergy syndrome. Oropharyngeal symptoms, the patient presented with an oral allergy syndrome and also known as pollen food allergy syndrome. It caused by cross-reacting antigen found in the pollens, fruits, nuts, and vegetables. It often causes an oral symptom but does not predict the food, which causes the EOE. Lack of significant proximal eosinophil does not predict the response of acid response. Because of the EOE is a patchy distribution, so the way to take a biopsy is 2 to 4 biopsies from the proximal esophagus and put it in one bottle, and also 2 to 4 biopsies from the distal esophagus and put it in the next bottle. And you have to sign the write on the bottle, this is from the proximal and this is from the distal esophagus. Why this distribution is important? Because if the distal predominant eosinophil may present better to PPI therapy. Patient with isolated or distal predominant eosinophilia has significant higher rate of histological remission with PPI compared to those with proximal predominant disease. Proximal predominant disease predict poor PPI response. Since your proximal count is low, as this patient, this pattern does not suggest a PPI resistant phenotype. Distal biopsy as the most important for the diagnosis. Study shows that the distal biopsy captures the diagnosis in the vast majority of cases. Your result fits this pattern. So, to memorize the endoscopic finding, you have to remember the word of fire. Fire is fibrosis, inflammation, rings, oxidate. And the symptoms, we have to think in dash: dysphagia, impaction, substernal pain, and heart pain. What is the treatment of EOE? Remember by 3Ds, which is drugs, dilatation. Further drug, topical swollen steroid like budesonide. PPI therapy is not only acid suppression but have an anti-inflammatory effect. Most recent is biological therapy, which map, which interleukin 4 and interleukin 16 blocker, stay approval and increase use of moderate to severe and fibrostenotic disease. And this is the most recent treatment. Diet, 6 food or 2 food or 4 food elimination diet. 6 food elimination diet like dairy, wheat, egg, soya, nuts and seafood. Step down approach, 2 food, stop dairy and wheat, or 4 food. Elimination diet highly effective but difficult to maintain. Dilatation only for the stricture or recurrent food infection. Safety and effects when combined with anti-inflammatory therapy. Here and now, so the treatment is, the answer is, we offer him a topical steroid and consuming and counseling for elimination diet. Here's our next case. It's 45 years old man with history of colectomy for ulcerative colitis, and he and 3-stage IPAA with ileostomy closure 2 months before presented with increased stool frequency, more than 10 liquid stool per day, associated with abdominal cramps. He has a bronchoscopy which show asymmetrical inflammation in the pouch, which are sharp demarcated as shown in this figure. Asymmetrical inflammation of the pouch. So, which of the following is differential diagnosis of most likely? Is it pouchitis? Is it colitis? Is it ischemic pouchitis? Or C. diff infection? Or it's Crohn's disease in the pouch? Recurrent of Crohn's disease in the pouch? To answer this question, you have to know the different pattern of inflammation in pouchitis. If it is ischemic pouchitis, so the presentation is asymmetrical inflammation with sharp demarcation. If acute pouchitis, diffuse inflammation throughout the pouch. Colitis, inflammation of the retained rectal mucosa above the anal transitional zone. If this C. diff infection in the pouch has 3 characteristics: frank erythema, spontaneous bleeding, deep ulcer including mucosa detachment. And if we look for this case, as we see, it is a asymmetrical inflammation. Asymmetrical here ulceration, here no inflammation, here no inflammation, and the ulcer is punched out. So my answer will be ischemic colitis. No, it's not pouchitis. Pouchitis is symmetrical inflammation. So the correct answer is ischemic pouchitis, not pouchitis, because asymmetrical. Here, the third case, we have a 45 years old woman visit your clinic for follow-up of her ulcerative colitis, for which he has been on tufasidenib, JAK inhibitor, 10 milligram twice daily for 4 months. Her diarrhea and abdominal pain have improved significantly. She feels nearly back to normal. She has a colonoscopy pending and she feels nearly back to normal. She has a colonoscopy pending to evaluate the mucosal healing. Incidentally, he mentions that he have a pain rash that come on 10th day ago that is affect her lower back but now seem to be on the mediastinum. On physical examination, this rash is a hemicircumferential area start from the right mid-lumbar region, crossing the right mid-axillary line, seen to be terminated before reaches umbilicus, which is the midline. It is not tender erythema, non-scarring papules. So, what's the next step of management of this patient? Do you start methylprednisolone? Do you stop tufascinib and start cyclosporine? Do you start acyclovir and hold tufascinib? Or you continue tenacity and start topical steroids? To answer this question, you have to know what's the diagnosis. Sure, it is a multidermatal herpes zoster. Multidermatal herpes zoster in patient being treated with JAK inhibitors. There is no rule of steroid. So if you found steroid in any choice, like B and D, it's incorrect. No rule of steroids in treatment herpes zoster. While the need to stop the current immunosuppressors is debated, there is no rule of cyclosporine giving her colitis of actual under control. So the decision is you should manage herpes zoster with antiviral treatment. So stop tufascinib or no. Tufascinib or JAK inhibitor associated to increase the risk of herpes zoster reactivation. The current recommendation to start antivirus treatment with cyclovir for 7 days. Patients who had not vaccinated against varicella zoster and have had chickenpox exposure are the risk for shingles. What is the shingles? Shingles is a reactivation of varicella zoster virus, the same virus that caused chickenpox, and lead to painful localized rash that follows a nerve pathway on side of the body. It's not life-threatening condition, but can be very, very painful and may lead to complications like post-therapeutic neuralgia. The clinical trial of tenactinib and herpes zoster event will generally be non-complicated and managed with a standard antivirus treatment, and the majority of the patients were able to continue or resume tufascinib treatment. So, currently, the safety of killed herpes zoster by using this vaccine with shingles. Shingles is a recombinant non-live shingles vaccine that is proven strong, long-lasting protection against herpes zoster, and its major complication, post-therapeutic neuralgia, and is preferred shingles vaccine worldwide, and is recommended for adults started for 50 years and for child above 19 years. In the clinical trial of tufascinib, generally not complicated and managed with standard antivirus therapy. The majority of the patient able to continue and resume to vaccine treatment. Finally, I would like to thank you for your attention. وإذا كنتوا لقيتوا أي حاجة استفادة في هذه المحاضرات يا ريت نكتب تحت. أي اقتراحات يا ريت نكتب. لو تحب تعمل subscribe I would be very happy. Thank you.